Okay, so this is chapters 25 and 26, so we're not going to get too much into the physiology of how the kidneys work, except where it matters. Um, so you might want to, it might help to kind of review kidney physiology if some of this is new to you or doesn't make any sense. Okay, so we're going to talk about disorders of renal function, which I guess we could start with kidney development. So what happens when the kidneys are originally developing? There's something called renal agenesis, which is one thing that can happen, which is where one or both kidneys simply don't develop. Okay, so this could be some kind of a genetic defect, or it could be just a lot of times it's just not known. But like something like 1 in 3,000 people may be born without a kidney at all. So it's not very common, but it does happen. If only one kidney is missing, then that is survivable because you can survive with just one kidney. Of course, if you're missing both kidneys, then that's not survivable. Okay, so that's something that the body can't deal with. So it needs to because the kidneys are there to filter blood, and that's not going to take place. Okay, so in both cases, the way that this is a lot of times discovered is that there's a decrease in amniotic fluid because as the kidneys produce urine in a baby, then that urine actually moves out into the amniotic sac and that becomes the amniotic fluid. So a lot of times, especially if both kidneys are missing, then there will be very low amounts of amniotic fluid and it's reduced if there's only one kidney as well. Okay, so renal hypoplasia. Hypoplasia, of course, hypo means reduced, so that means the kidney is smaller than normal, and that of course too may be bilateral or unilateral. And then there's something else, we're not really going to cover it, called renal dysplasia. And renal dysplasia is just where the cells are malformed, and a lot of times that can cause the tubules to form cysts. Okay, so these renal tubules, they may form these cysts, and that can cause well, I mean, the cysts are actually part of the problem. Okay, um, so what do the kidneys do? They filter blood. Okay, so that is their function. That's a pretty clear function that they have, and the kidneys really don't make up that much of your body. 0.5%. That's not even 1%. That's a half a percent of your total body mass, and yet they get 20 to 25% of the resting cardiac output. So that means that as your heart is beating and it's pumping the blood out into the aorta and then the descending aorta, then that's going to branch off, and it's going to branch off into the renal artery. Okay, so there's a left and a right, so it's going to go to the other side as well. And then that blood is going to flow, it's going to divide into smaller arterioles, and then those arterioles, there's an arteriole that will feed nephrons, okay? And the nephrons sit kind of like this. If we were to draw the nephrons, they would kind of sit down here, and they sort of point down the um, into the pyramids or the medulla of the kidneys, okay? All right, and then those will drain, and they drain into the calyces and the pelvis of the kidney, and then they drain down through the ureter and go down to the bladder. Okay, so the left and right renal artery enters the kidney, branches into arteries and arterioles, and each nephron, so a nephron, this is a nephron here, each nephron receives one afferent arteriole, and it's really the nephron that's doing all the work. Okay, so as blood moves in through this afferent arteriole, then it's filtered by this glomerulus, and then that filtrate, which is missing things like large proteins like albumin, shouldn't have very much of that in it. It'll have some, but not very much. And it's mostly just water, ions, and other small molecules that make it through. Blood cells stay in, large proteins stay in, and those just kind of move out through the other side. Okay, but of the blood that makes it through the afferent arteriole, only about 20% of it is actually becomes filtrate and moves into the nephron. Okay, the rest of it just simply goes through and then passes right back out the other side and stays in circulation. Okay, so there are about 1 million nephrons in each kidney, and this is really what, like I said, that's what does the filtering. That's where your kidney function is affected. If this nephron doesn't work, or if you have a reduced number of nephrons, or if parts of the nephron doesn't work, we're going to talk a lot about glomerular diseases, then then that's going to affect the function of your kidney because it's going to affect the filtration, and that can really add up. Okay, so I just mentioned the glomerulus. So we have our afferent arterial. We can draw that on the top or the bottom. Afferent arterial that brings blood in, and then the efferent, which allows blood out, and this capillary ball is the glomerulus. Now that glomerulus is surrounded by something called the Bowman's capsule. Okay, so the Bowman's capsule surrounds that. And so all of this filtrate that moves out into this area then can move into the nephron. Okay, and then the nephron, you got your descending loop, your loop of, or your proximal tubule, descending loop, ascending loop of Henle, and then your distal tubule, and then the collecting duct. Okay, that's not really to scale. This would normally go way down like this. Okay, all right. So glomerular capillaries in the Bowman's capsule are both made of epithelial cells sitting on a basement membrane. They're so tightly attached to each other that they share one basement membrane. The epithelial cells of the Bowman's capsule stand up from the basement membrane on foot processes, which we'll look at in the next slide, leaving pores between the feet for filtration. So remember that. That's what's going on in the glomerulus. That's the job of the glomerulus. Blood enters, and then it gets trapped in this maze of capillaries. And so if we sort of imagine moving in through here, and then we kind of move down to this picture and we say, okay, this is the blood, and then pressure is going to push it between these little slits, and that's going to allow it to kind of filter through all of this stuff and then feed out into the Bowman's, or into the Bowman's capsule. And then from the Bowman's capsule, if we look up here, then it moves and it enters the nephron, and then it moves out here completely through the nephron, and that's where something called reabsorption and secretion take place, okay, is in the nephron. So the rate at which this filtration can occur, okay, so if we have a lot of pressure, a lot of blood pressure, a lot of blood movement through there, then that's going to increase the pressure here, and we're going to have more filtrate moving out of the glomerulus. Okay, so we call that glomerular filtration rate when we're talking about how fast it's filtered through there. And so a higher rate of filtration means that it's going to move through the nephron more quickly. Okay, which means you're probably with a higher GFR. So if you increase your glomerular filtration rate, you're going to have an increase normally in urine output. Okay, because you're pushing more fluid through. If you have a higher GFR, that means that you're dumping fluid more rapidly, which means that it could dehydrate you. Now, normally when everything's working properly, this is serving you, I mean, this is working to your advantage because that's a way of controlling um, fluid levels in your body and controlling blood pressure. So you can see here at the afferent, there are smooth muscles here that can say, okay, blood is flowing through too quickly, and that's measured by this area here. Okay, so as the fluid moves past this, it's sort of monitoring how much sodium is in there, how much blood pressure is in the nephron tubule, and it's saying, okay, we need to constrict and reduce the amount of blood flowing into the glomerulus, or it may say, okay, we need to dilate, we need to relax and allow more blood to flow through. So your body is constantly making these adjustments, trying to get your glomerular filtration rate and all of the things that are reabsorbed, like salts and urea is another thing. Here, we'll push those that direction. Um, trying to control the rate at which urine is produced. Okay. So we call that glomerular filtration rate, usually about 180 liters per day. When you add up all of the nephrons in both of the kidneys, we see that about 180 liters per day is actually filtered. Okay, so that's how much is filtered through, but we only make about 1 to 2 liters of urine per day, which means, kind of like I was drawing up here, that means that most of the water anyway, and most of the salts too, are reabsorbed. So water moves out, and then that happens primarily in the proximal tubule. Okay, so water, and then we'll just say salts move out. We'll just put sodium chloride, although other salts move out too. Um, and then in the ascending tubule, it's mostly just sodium, potassium, chloride. Those guys move out. So we have most of the filtrate that moves into this nephron. Remember, that gets filtered through this glomerulus. Most of that gets reabsorbed, and it has to, otherwise we would dehydrate in a matter of minutes. Okay, so first thing we're going to talk about, since we're talking about this glomerulus, okay, so the afferent arteriole, the glomerulus, and the efferent, okay, um, and then that's of course surrounded by Bowman's capsule, and then feeds into the nephron. Okay, so we're going to start out talking about disorders of glomerular function. And of course, if you're talking about disorders of glomerular function, you're going to be talking about filtration and how quickly or slowly filtration happens, which means a lot of that's going to affect GFR. Okay, and all, I mean, if you have backflow or something like that, that can affect GFR too. So GFR is affected a lot of times, but it's especially affected with glomerular function. So glomerular diseases are one of the most common forms of kidney disease, maybe primary, which means that it originates in the glomerulus, like what I was just talking about, or secondary, it may be part of disease affecting other organs. Okay? So it could affect other organs, but then it may also have some kind of an effect on the glomerulus as well. So maybe in the case of lupus, it's producing antibodies that somewhere else that will land here in the glomerulus and then affect filtration. Okay, so effects of glomerular disease. Now, you can either have, with glomerular disease, you can have either too much is being allowed through, which means like something like proteins are getting through that shouldn't, um, or too little is getting through. It all depends. It all depends on the characteristics of whatever disease it is that we're talking about. So one thing we might see is elevated blood urea nitrogen. Okay, so really, when we talk about blood urea nitrogen, mainly what we're talking about is urea. And urea is just a molecule that is made from broken down proteins. Okay, broken down proteins because those are all nitrogen compounds, amino acid, so proteins and amino acids. And they all have this little NH3 or NH4, NH3 group. And that's a form of that is what urea is. Okay, so that's just what it is. We find it in urine. That's why they named it urea, I think. That's how I remember it anyway. But that's all they are. It's broken down proteins and amino acids. Okay, so we can kind of see that this is a way, this urea is sort of a way to detect how well the kidneys are working in a lot of ways because as the urea moves through the tubules, okay, or this is a nephron, okay, so the glomerulus is over here. So some of this urea is secreted, some of it moves in, some of it moves out, and so the urea has a very predictable way of behaving. So if you have trouble with the glomerulus, okay, then we may see that maybe this urea isn't being handled properly by the nephron, which means that the kidneys aren't doing their job, and so that may leave the urea in blood flow, okay, or in circulation. We'll say leaves it in circulation. Okay? And so if it's leaving it in circulation, that's an indication maybe that the kidneys aren't functioning the way they're supposed to. So we may see elevated blood urea nitrogen. We may see lots of different things, and we'll talk specifically about each disorder or disease and see exactly how that works. Okay, so you may see sudden or insidious, so it may be very quick, it may be a slow onset, but you see hypertension. Now that also makes sense since the kidneys are filtering blood. Then you may see a case where maybe they aren't letting the blood in, or maybe the kidneys are reabsorbing too much water. Remember how that can happen? If the kidneys are reabsorbing water, well, that's increasing your fluid volume, and that's going to increase pressure as well. Okay, so it's not really straightforward always exactly how a glomerular disorder is causing increased blood pressure, but for the most part it's because blood isn't being allowed to go in, or somehow this is sending a signal saying that, telling it to reabsorb more water. Okay. You may see proteinuria, which is too much protein. You may see not enough protein. Okay, so you may see less protein in some cases, but proteinuria, which is urine or protein in the urine. So that means as it's flowing through, here's your glomerulus. It's supposed to be filtering out that protein, but instead of filtering out, it's letting it through, and so that moves into the tubules, and then it just simply moves out as urine. Okay, so you're going to see an increase in the level of protein in the urine. Decreased GFR, you may see decreased GFR. Um, if you see that, you may see elevated plasma creatinine. So creatinine is another one of these molecules that's made primarily in the muscles as a breakdown product of creatine, which is a way for the muscles to get energy. It's something that holds on to ATP. So that may break down, and usually we produce creatinine at a pretty constant level. Okay, so that moves into the tubules, and that's usually pretty constant. You can pretty much check your creatinine levels on at one time. Okay, so it's in the blood, and it does move into the urine, and you can pretty much check it at one time, and then a few months later check it again, and it should be about the same as long as everything is okay. But if the kidneys are not functioning properly, then we may see an increase in creatinine. So we may see an increase in creatinine. We may see an increase in my blue and my green look almost the same. We may see an increase in urea. Lots of different possibilities here. Okay, so that would be from reduced creatinine clearance. We're not able to clear it, which means it backs up and it stays in the blood. Okay, glomerular damage causes a decrease, so it may cause a decreased glomerular membrane surface area. So remember, we need our glomerulus to have the proper surface area, but if it gets damaged and replaced with scar tissue, then we may reduce that surface area. So that means you can't get as much filtration to happen as you can when the glomerulus is working properly. Okay. Let's see, glomerular capillary blood flow, which triggers mechanisms to increase blood pressure. So like I said before, we have constant monitoring. The glomerulus, if we go back for just a second, the glomerulus is constantly monitoring, or it's called the macula densa. It's constantly monitoring what's going on in the tubules. Okay, so if it sees something wrong, it doesn't know why it's wrong, but it sees something wrong, it may adjust this afferent arteriole and change your GFR. It may release renin, which is going to change the blood pressure, and it may be an improper response. Okay, so when something goes wrong, a lot of times your body doesn't exactly know. It may just say, oh well, things are moving through the nephrons at the wrong rate. The sodium levels are wrong, the water levels are wrong, and so it may adjust by increasing blood pressure, thinking that maybe that's the source of the problem, or actually it doesn't think at all. It's just monitoring this one little thing moving past here, and its response is going to be the release of renin. Okay. So increased glomerular capillary permeability. Um, so we may have increased capillary permeability. We may have decreased capillary permeability. And loss of negative ionic charge barrier result in passage of plasma proteins into the urine. Okay, so if you can imagine, sort of, here's your, here we'll make it red again. We'll erase some of this other stuff. So you can sort of imagine if we have the glomerulus, and maybe the glomerulus becomes, we'll say this is that capillary ball that's going all over the place. Okay, so maybe it becomes a little bit, I know this is a horrible picture, but basically if we have blood, which I'm going to make blue here since I made that red, that's trying to flow through and it's able to just simply permeate, well then maybe something like proteins are also able to get out, and then those can move into the nephron. And if those move into the nephron, so these are proteins that are supposed to be held, but we've got, we have very dramatically our glomerulus, which is the red here, is just simply falling apart, and all these proteins are just leaking out, and they're moving into the nephron, and then, they can become urine. And if they're in the urine, then they're not in the blood, and so you're losing plasma proteins. Okay, and so you have proteinuria, like I mentioned before, protein in the urine. Okay, so now and I'll try to explain this concept too, but if you have, and this is something that's very important for you to understand, so kind of try to pay attention, or look it up again if you don't quite follow along. But if you have, let's say that the kidneys aren't working, whatever, and you're losing blood, or you're losing protein through your urine. Well, what does that do in your blood? If your blood is used to having this much protein in it, and when we talk about protein, the main protein we're talking about is albumin. Okay? Now, albumin isn't really, I mean, it has, its main function in the blood is to kind of keep the osmotic pressure correct. So if we have a certain number of proteins inside and outside, and those concentrations are the same inside and outside, then there's not going to be any net water flow. So water's going to maybe move out of the capillaries, and then it's going to move back into the capillaries. Some of it will then leave through the lymph system, but we kind of talked about that a while ago. Now, if we're in a situation where we're losing protein, okay, so we're losing protein in the urine, then that protein's not going to be in the blood anymore. So what that's going to do, and this is important, so remember all those little green dots that were there? That was the protein. Well, we just lost that protein in the urine. Then that means that water is going to be drawn out here through osmosis because there are more particles on the outside. So that means we're going to have more water moving out of our capillaries and staying in the extracellular fluid where there are more proteins. Okay, so we can make this really dramatic, and we can say there are a whole bunch of particles out here, okay, and not very many in the blood anymore because we lost those in the urine, and so there goes the water. The water is going to go out here, and that's edema. Okay, so that's a buildup of fluid outside of circulation in the interstitial fluid, okay, or in the interstitial tissue. Okay, so resulting hypoalbuminemia. Okay, so if we remember that albumin is this main protein that's found in the blood, and if it's hypo, that means there isn't enough of it, then, or that it's reduced, that means that you're going to, the colloidal pressure, or this osmotic pull, is going to pull more fluid into the interstitial space. So hypoalbuminemia encourages plasma fluid to stay in the interstitial spaces, which is edema. It's important that you understand that concept because there will be questions about that on the test. Okay. Glomerular disease. Okay, so So we had effects of glomerular disease. Now we're going to talk a little more specific about some glomerular diseases. Origin may be non-immunologic, which means that, it's something like an infection or damage or something like that. Um, Hypertension, or it could be immunologic. So when we talk about the immunologic, we're talking about the immune system. We're talking about antibodies. Okay, antibodies trying to attack an antigen of some sort. Okay. Um, and then toxic. Toxic technically is going to be considered non-immunologic, but that comes from drugs and chemicals. Okay, so named according to the tissue appearance. So what it looks like, if it's proliferative, if you have increased proliferation of glomerular cells, since we're talking about glomerular diseases, that's going to be proliferative, membranous thickening of the glomerular basement membrane, so whatever may cause that. And when you view it, you have a thicker basement membrane. Sclerotic, increase in extracellular material around the glomerulus. Okay, so that means, so we're talking about this area, these areas in here. Okay, so around the glomerulus, you may see an increase in extracellular material. So you may look at it under a microscope and you may see a whole bunch of stuff in here. Okay, so that's sclerotic. So the changes can be diffused, which means that it involves all the glomeruli, or it could be focal, it only affects some glomeruli, or it may only affect a certain section of the glomerulus, or the glomeruli, or mesangial, and that's segmental, by the way, focal and segmental, and then mesangial affects only the mesangial cells, which I just kind of covered up here with black, but these are the mesangial cells. These guys right here. So, it could affect any part. There are a lot of different parts of the glomerulus. We've just talked about it as a capillary ball, but it's got an inside, outside, it's got space around it, it's got cells between it, and all of those things can be affected, so they have to account for all of those things when they see them. Okay, so immune mechanisms. So you can have immune mechanisms may include antibodies. So these are, in this case, we can actually see antibodies that are actually, let's see, so antiglomerular membrane antibodies leave circulation and interact with antigens that are present in the basement membrane. So that means there are actually antigens, in this case, that are part of the basement membrane. Okay, so that's what I'm kind of trying to circle here. They're actually part of the basement membrane, and the antibodies are attacking them. We may see immune antibody complexes that come in. Okay, so this is a type 3. Remember, these guys may have been formed somewhere else completely in the body, but as they move through the blood, they move into this area and then they may clog things up. Okay, so things may get trapped in this area, and you can see here that there's a deposit of them that's formed. Okay, and so that can cause problems as well. Okay, so a couple of different mechanisms that can take place there. All right, disorders of glomerular function. So this is what we're going to go through: acute nephritic syndrome, rapidly progressing glomerular nephritis, nephrotic syndrome. Okay, so this is fun. We have nephritic and nephrotic. Okay, don't blame me, I didn't name them, but they're pretty different. Immunoglobulin A, nephropathy, hereditary nephritis, and then chronic glomerulonephritis. Okay, so we'll talk about some of those. So acute nephritic. Okay, so I'm very sorry about this little I versus an O, but in this case we're talking about nephritic. We're talking about the one with the I. Acute inflammatory process that occludes. So remember, the glomerulus can either be blocked, okay, or it can become too permeable. It can become leaky. So we've got a couple of different choices of things that can happen here with the glomerulus. In this case, it's being occluded, which basically means that the glomerulus is being blocked. So that means things that it's supposed to be letting through, it's not letting them through. Okay, so it occludes the glomerular capillary lumen and damages the capillary wall. So it's considered proliferative. Okay, proliferative inflammatory response we talked about earlier in terms of categorizing them. It occludes the glomerular capillary lumen. Okay, and damages the capillary wall. So we're talking about the glomerulus, okay, of the glomerulus. Okay, characterized, and hopefully this makes sense. If it's occluding, hopefully it makes sense that it's characterized by a decrease in glomerular permeability. Okay, so hematuria from capillary wall damage. Okay, so this means, let's see, so this means that we're seeing blood in the urine. Okay, if we see blood in the urine, it's because there is damage to the capillary wall. So damage to the capillary wall, we're going to have blood leaking into the glomerulus, and we're going, or into the nephron, and then we're going to see that blood in the urine. A lot of times they talk about that as being like cola-colored urine, something like that. But you're going to see blood in the urine. Proteinuria is slight. Okay. Now, the reason for that is because you have overall an occlusion. Yes, sometimes you get damage to the capillary wall, and you may have some blood that moves in, and maybe some proteins move in with that too. But overall, you're occluding, you're blocking the filtrate. And so you're going to see a very slight increase in protein, or slight protein in the urine. You're going to have nitrogen waste build up in the body, okay, which is not good. It's waste, and so your body needs to get rid of that. Oliguria, so that means small amount of urine. That's because you have a decreased GFR. Again, because you have occlusion. Okay, so characterized by decreased GFR, hypertension, so you'll see hypertension. You may see, because of the backup, you may see edema, extracellular fluid accumulation, which is, kind of related to edema. So here's an example, acute post-infectious glomerulonephritis. So it's acute, so it fast onset, occurs after an infection with certain strains of streptococcus, 7 to 10 days after strep throat or other viruses such as mumps, measles, and chickenpox. So this is something you see, and usually it will resolve. So hypercellularity, infiltration of leukocytes, neutrophils, and monocytes. So you're going to see some of this stuff take place in the nephron. Okay, so proliferation of endothelial and mesangial cells. So this kind of comes back to this word here, proliferative, that we talked about before. Okay, so proliferation. So we're going to see an adaptation where you have an actual increased number of cells. Okay, so that's acute nephritic syndromes. Rapidly progressing glomerulonephritis, and this is kind of a subcategory. It's a severe glomerular injury without a specific cause. Okay, so we don't know, or we'll know what causes it, but it can be a number of different things. So it's nephritic, rapid decline of GFR, focal and segmental. So that's where we went back to our where it takes place. Focal and segmental proliferation of glomerular cells. Monocytes and macrophages move in, so those guys move in. The Bowman space is lost, so your glomerulus and then your Bowman's capsule that sits around it. So that space may be completely lost. Okay, included. Rapid progression, often within a matter of months, and it can progress to acute renal failure and death if you don't find the source of it and then treat the source, if possible. So it includes immune complex disorders. Okay. Immune complex disorders like systemic lupus erythematosus. So SLE results from antibodies against nuclear proteins, and one of these proteins is DNA. So that means it can happen in a bunch of different cells. Okay, a bunch of different cell types, a bunch of different organ types, but they will get trapped in this in the glomerulus, and then the macrophages move in. The monocytes move in, turn into macrophages, and then you have this sort of inflammatory response, and white blood cells are moving in. and you have this occlusion, and everything moves into the extracellular space, and you lose that Bowman's capsule space. Okay, so it can affect numerous tissue types. So that's SLE, or systemic lupus erythematosus. Goodpasture syndrome, which are antibodies against. So this is actually when antibodies attack parts of the glomerular basement membrane that also affect the pulmonary incidentally. So we're talking about the kidney right now. So we say, oh, well, it hits the glomerular basement membrane. So that's interesting because that's right here in the kidney. But one way you know that, or one of the hallmarks of Goodpasture syndrome, is that it also seems to affect the lungs, the pulmonary alveolar membrane. So there's obviously some kind of antigen that exists in both of these places, in the glomerulus, and it exists in the alveoli. So it exists in both of these places here. Okay, and that's Goodpasture syndrome, and that's just, yeah, it's your immune system is trying to attack some kind of antigen in the glomerulus. Okay, so glomerular nephritis, post-infection glomerular nephritis, and this is a picture showing, so this is after like an E. coli infection or maybe the mumps or something like that. Yellow stain shows complement, so we didn't even talk about complement when we were talking about this immune response. Complement, which is shown here in yellow, okay, so in this picture in yellow, those are complement proteins, which means that if you were to, take a biopsy, take a slice of this, and then stain it against complement protein, you can see that yes, your immune system is attacking its own glomerulus. Okay, and that's going to, that's going to cause some problems. Okay, some occlusion, some blockages, and some overall damage. Okay, so now we're going to talk about nephrotic. Okay, so we were talking about nephritic. Now we're going to talk about nephrotic, not a specific glomerular disease, but a group of clinical findings that result from an increase. Okay, so remember we had a decrease earlier, occlusion earlier, increase in glomerular permeability. Okay, when we have an increase in glomerular permeability, guess what? We start to lose proteins. Proteins start to leave in the urine. And so that's the biggest difference. Okay, is that, and that's one of the big differences between this nephritic versus nephrotic, is that you have massive proteinuria. Okay, so you have lots of proteins in the urine. Okay, so maybe again primary disorder, which is the more common in children, or which is more common in adults, is a secondary complication to diseases like diabetes, lupus, amyloidosis. So any number of diseases can lead to this breakdown of the glomerulus, increased glomerular permeability, massive proteinuria greater than 3.5 grams per day, hypoalbuminemia, which means that these proteins that are leaving in the urine are no longer in the blood, and so you have reduced albumin in the blood, uh, lipids in the urine, and again, that concept that I want to make sure you understand: if the proteins are leaving in the urine, then they are not in the blood. And so that messes with, that's the concept I really want you to get, is that this albumin is affecting the osmotic capacity of your blood. And so a lot of times you might need to give albumin as intravenously to sort of restore this this osmotic capacity of the blood. And so yeah, when that's decreased, then it will, I know this is the second time I'm drawing it, but it will draw that water out, and that's edema. Okay. Um, let's see. Let's see. So lipids in the urine, lipids in the blood. That's because of and that's actually due to the loss of proteins and the activation, so sort of your your liver responds and your cells respond by increasing the amount of energy and putting more lipids pretty much everywhere. Okay, at risk for thrombotic complications. Some of these proteins, and see, this is one of those tricky things. You can read this, oh, you're at risk for thrombotic complications. Well, okay, whatever that means. But if you're losing proteins, remember your liver is making proteins that are necessary for clotting. So even though we talk a lot about albumin, remember there are complement proteins and there are clotting proteins that are in your blood. And so as those leave in the urine, they're not supposed to, but as they do, that can cause clotting problems or thrombotic complications. So again, I put down here, remember when albumin levels decrease, fluid will leave circulation and enter the extracellular space. And don't forget about this. Don't forget that, it's an easy thing to forget because we kind of simplify or generalize. And we say, oh, well, the main protein in blood is albumin, which is true, but don't forget that the liver are making lots of proteins. Lots of different necessary proteins are circulating in your blood all the time, and that some of those have to do with clotting. So make sure that makes sense to you. Okay. A couple of others that we'll just mention here. Immunoglobulin A nephropathy, something called Berger's disease, or Berger disease, named after somebody. IgA, immune complexes in the mesangium of glomerulus lead to inflammation. Remember, the mesangial cells are the cells that kind of sit in between. Okay, so they kind of sit in between or in the extracellular fluid between the glomeruli. But that can lead to inflammation. Most common cause of glomerular nephritis in Asians. Onset is usually in the 20s or 30s. And so you might see some blood in the urine associated with this as this sort of pokes through, and you might see some, and also some proteins might leak into the urine. So those might escape in there. Alport syndrome, which is hereditary, and that's actually a defect. So that's a hereditary, it's just sort of made wrong. Defect of glomerular basement membrane, and it's usually X-linked, or it's X-linked, which means that it's on the female, but boys are more severe because they only have one X chromosome. Meanwhile, girls have two X chromosomes, so they have a backup. Boys do not. And again, blood in the urine may lead to chronic renal failure. Okay, so chronic. So most of these we've been talking about have been acute, but chronic. So chronic phase of a number of types of glomerulonephritis. Some acute forms of these glomerulonephritises will resolve completely, but others progress at variable rates. So sometimes these things can kind of linger, hang on, repeat, keep coming back. So some with chronic glomerulonephritis have no history of glomerular disease that they've been aware of. And so you kind of have this slow, ongoing, constant damage, and the body is adjusting, and you may not even, maybe completely asymptomatic. So it represents the end result of asymptomatic forms. Yeah, so you may have some, so characterized by small kidneys, sclerosis glomeruli. So that means buildup of products, whether they're fibrous or some other kind of cells between the glomeruli, so within the glomerulus. Develops insidiously, slowly, and progresses slowly to end-stage renal disease over a period of years. Okay, so glomerular lesions associated with systemic disease. I kind of mentioned SLE, systemic lupus erythematosus, which is one of these things where you have the antigen antibody complex. So this may have happened somewhere else. This then will move down into the glomerulus, and then you have a whole bunch of these guys that are building up in there. Okay, and they can cause that nephritis, nephritic syndromes. Okay, um, they just sort of build up in there. So it's a type 3 hypersensitivity, immune complex mediated autoimmune antibodies attack numerous tissues, and of course, you have maybe some blood in the urine, hematuria, proteinuria, so you've got proteins in the urine as well. Now, the other one we're going to talk about is diabetic glomerular sclerosis, and that is associated with like a diabetic nephropathy. So mechanisms of glomerular change is uncertain. So we're not exactly sure what happens, but of course it's probably going to have something to do with increased glucose. Okay, so we have increased glucose levels, and that is somehow messing with, to put it, in official terms, it affects the basement membrane and the mesangial matrix. So the basement membrane where the Bowman's capsule and the glomerulus are, plus those spaces in between and some of those cells that are in between these. So it can affect any of these areas. Okay, so closely linked to those with diabetes, increased GFR associated with microalbuminuria. So not as much albumin in the urine, okay, which means that it is staying in the blood. Okay, so increased GFR, and yet your albumin levels are reduced. Okay, let's see. So urinary albumin greater, and this will change actually as it progresses. Um, you may see a change in GFR, but this is what you tend to see early on. Okay, so you see very little albumin, and yet your GFR is increased. So urinary albumin greater than 30 milligrams over 24 hours and less than 300. So when we see a lab result like that, then this may be something that we want to look at. So early glomerular changes can be reversed with careful control of blood glucose levels and control of hypertension. Smoking cessation can all help to prevent this from taking place. But this is something that needs to be watched for in diabetics. You need to sort of watch to make sure that this isn't or to monitor kidney function in someone with diabetes. Okay. All right, so now we're going to move from the glomerulus into the renal tubules. So the renal tubules filter blood by selectively reabsorbing the items the body needs for survival. What does that mean? That means that as all of these things, the water, the salts, all of this stuff, there's a lot of good stuff that moves into the nephron. And if you really look at this, as things move through the nephron, their next stop is the bladder and then urine. Okay, so that means that we need to reabsorb most of this stuff, and most of it's reabsorbed in the proximal tubule. So as soon as it leaves the glomerulus and moves into that proximal tubule, most of it is reabsorbed back into the body. Then we have in the descending loop, we have water being reabsorbed, and then in the ascending loop, we have salts. Okay, so specifically sodium, potassium, chloride. Salts are being reabsorbed. Okay. And then over here in the distal tubule and the collecting duct, that's where we have hormonal control. Things like aldosterone may say, okay, we're going to reabsorb more sodium. Okay, and of course chloride is going to move with that, and then water is going to follow it as well because it's going to change that osmotic potential. And then over here we have maybe vasopressin, which is putting more aquaporins in, so more water is being reabsorbed. Okay, so we have lots of control, and hormonal control, like I said, usually happens over here in the distal tubule and collecting ducts. But in general, we have it's a pretty program type of control that happens over here in the loop of Henle. And that's why we have things called loop diuretics. So loop diuretics can block these salts from being reabsorbed. Okay, that's what we're seeing here with this. So it can block these salts from being reabsorbed, which means that those salts stay in. Okay, let's just think about this for a second. Let's just say we take the drug like Lasix. Okay, so these salts that are supposed to be reabsorbed are staying in the nephron. Well, if you have salts staying in the nephron, then that's going to keep water in the nephron. Okay, so that's just osmosis. That's just the way it works. If you've got more particles in here, the water's going to stay in here. You have more water in here, it's going to be more urine. Okay, so water only moves out if there's a higher concentration of solutes into which it can move, osmosis, so it only moves to where there are more particles. Most reabsorption happens in the proximal tubule. Fine-tuning occurs in the distal tubule and collecting duct. I mentioned ADH, aldosterone. Lasix blocks the sodium potassium chloride cotransporter. Okay, so that's what that means. Sodium, potassium, sodium N, potassium K, chloride C, and then C cotransporter. Which I kind of wrote that in a redundant way, the NKCC cotransporter. The NKCC is the sodium potassium chloride cotransporter. So the sodium potassium chloride cotransporter is what I wrote there, which isn't really right. But either way, it blocks this right here and doesn't let the sodium, potassium, and chloride leave the way it's supposed to. Okay, so Lasix blocks that, which prevents water and solutes from being reabsorbed, so fluid level falls in the body and urine volume increases. So that's kind of what I demonstrated there. Okay. All right. So keeping that in mind, we're going to talk about some tubular, okay, and interstitial disorder. So we're talking about the nephron tubule, which is the yellow parts here. Okay. Those are the nephron tubules. Okay, so pyelonephritis is a renal disease affecting the tubules, interstitium, and pelvis. So pyelo actually refers to the pelvis of the kidney. So acute pyelonephritis is an acute infection. Okay, so mostly E. coli. Okay? Infection of the renal pelvis interstitium. So the outer, around the cells, outside the cells, interstitium. Infection. So, and here are some other potential pathogens that may cause this. And in general, ascending route of infection through lower urinary tract is most common. Okay, so that means that you get an infection. In general, it usually comes up from the bladder. Infection can also occur through the blood, so that means if you have, and of course the blood is going to affect everything. If this pathogen happens to get into the blood, make its way into the blood, then that can cause infection too. But yeah, most commonly we're talking about some kind of infection through the urinary system. Okay, so risk factors: catheterization, urinary tract instrumentation, and then vesicourethral vesicourethral reflux. Basically, that means it's moving up from the bladder. Okay, so the bladder's down here trying to collect urine, and then you have movement reflux, which means movement backwards. Pregnancy may lead to some kind of blockage, neurogenic bladder, where the bladder isn't emptying properly because of usually because of some kind of neuronal damage. Yeah, so neuronal damage. Clinical presentation includes chills, fever, headache, back pain, tenderness. Let's see. Over the costovertebral angle and general malaise, bladder irritation, dysuria, which is pain and urination, frequency and urgency. Okay, so that's pyelonephritis. Chronic, or that was acute pyelonephritis. Chronic pyelonephritis is just when this continues to happen. Persistent, recurring episodes of acute pyelonephritis that leads to scarring. So acute pyelonephritis may cause pain. It may cause you to be sick. and it will affect filtration on some level. Chronic pyelonephritis, you're actually causing some irreversible damage to the kidneys. Okay, so you're actually causing some scar tissue to form. So risk of chronic pyelonephritis increases in individuals with renal infections and some type of obstruction. Okay, so that should make sense. So here, sorry, going back, the acute pyelonephritis, some kind of an infection happened, and then if you have this mixed with some kind of obstruction, then that's more likely to cause the permanent damage. Okay, cysts. Polycystic kidney disease. Dilation of tubular, so again, we're talking about the nephron tubules. Tubular structures to form a fluid-filled cyst. Cysts may be single or multiple, inherited. So this is a primarily an inherited condition, may be dominant or it could be recessive. And diagnosis, radiographic studies, ultrasound, CT, some way to actually get in there and look at what's going on, because it's not always obvious as it is in this picture. Okay, so kidney size is increased due to the cysts. So manifestations may be asymptomatic earlier if cysts are small. If they're small, the nephron tubule kind of pouches out a little bit. And if you have small cysts, I don't know if that's considered small, but if you have small cysts, you may not notice. Now, if you have a whole bunch of these, or if it as it progresses, then there may be pain, may be debilitating, gross hematuria from bleeding into a cyst. So if the cyst bursts or if there's damage that takes place, then that blood could move into the nephron. Infected cysts from ascending urinary tract infections. Now, one of the other problems is that if we look at this picture here, you can see there's a giant cyst right there, but that may collect fluid. And so stasis is never that good. When a fluid is just sitting in one place for a really long time, pretty much anywhere in the body, whether it's cerebrospinal fluid or blood or lymph or whatever, when fluid sits in one place for too long, that kind of increases the chance of not only a thrombus, like in the case of blood, but infection. Okay, so infected cysts from ascending urinary tract infection. So something that may just be that those bacteria may just be washed out. A cyst may allow them to take hold. So hypertension from compression of intrarenal blood vessels. Remember all those arterioles and arteries that are moving into the kidneys? Well, if you compress those, then you may have an issue with hypertension, because you're not able to push blood into there where it's supposed to go. Or with activation of the renin-angiotensin mechanism. So you may confuse, I don't mean to be too plain in my language here, but you may confuse the renin-angiotensin system, and it may think that it's not getting enough fluid, and so it may think that your body is depleted of fluid because it's being blocked, and it's going to send a signal saying, hey, we need to conserve fluid, and maybe your body has plenty of fluid. And so, but it's still sending that signal saying, okay, we need to slow fluid movement through the kidney, or we may need to reabsorb more sodium, more water, and then your blood pressure is just going to increase, even though it doesn't have to. And then, of course, this could slowly progress to end-stage renal failure. Okay, so now some obstructive disorders. Okay, so obstruction can occur anywhere from the urethra to the renal pelvis and at any age. And so we can see a number of things here. Could be developmental defects, pregnancy. So you can see here's the baby kind of pushing on the ureter, which could cause an obstruction. Of course, it mentions a tumor. A tumor could do the same thing. Not that a pregnancy and a tumor are exactly the same. Benign prostatic hyperplasia, so the prostate gland, which is where urine actually flows through. The prostate gland, if that's enlarged, that could cause some blockages, and kidney stones, which are actually the most common. Okay, so kidney stones can cause blockage as well. So clinical manifestations depend on the site of obstruction, the cause, so where it's happening, the cause, what's causing it, rapidity with which the condition develops, how quickly it sets. Or how rapidity or the speed of onset. So signs and symptoms, pain. Okay, pain, the location and the type depends on where the obstruction is. Okay, so that's pretty reasonable. You may see hypertension, more common in unilateral obstruction, in which secretion of renin and enhanced response to decreased renal blood flow. Okay, so you may see that in that case. Okay, so let's kind of move on and keep talking about some obstructive disorders. Hydronephrosis due to obstruction. This is pretty straightforward. If you have an obstruction, that means the fluid's not draining the way the fluid is supposed to be draining, which means that it is backing up. Okay? And it's backing up into this renal pelvis and the calyces. Okay? So that's hydronephrosis, dilation of the renal pelvis and calyces, left with atrophy of the renal tissue, which you see actual atrophy that can take place over time. And it's caused by obstruction to the outflow of urine. Maybe acute, happen very quickly, or it may be insidious, where you may not even notice that your urine flow has changed, and but yet it's still constantly backing up, and it's constantly keeping that pressure in the pelvis and the calyces. So obstruction may occur at any level of the urinary tract, so anywhere after as it leaves the kidney. And of course, we're back to this concept. Stasis of urine may lead to infection, and it may lead to more stone formation, or it may lead to stone formation if that wasn't already the case. Okay, so stones, kidney stones. They're renal calculi. So calculi, I think, comes from calcium. Okay, because when they were first discovered, they look like calcium crystals, and a lot of them are made from calcium molecules that contain calcium. They're polycrystalline structures, so they're crystals. Okay, so you have a crystal that forms, then you have another crystal that forms on that one, and so you have this formation of these crystals that can grow. Okay, and so you have this lattice of a crystal, and that's what crystals do. They sort of start at one point, and then they just kind of add on to themselves, and they grow and they grow and they grow. Okay, so but in order for that to happen, you need a supersaturated urine. So that means that you have to have these particles that are in it at such a high concentration that they don't stay dissolved. Okay, so they're supersaturated. Okay, so this could happen like if you're boiling salt water and you boil out all the water, then after a little while all the salt that was dissolved will start sticking together. But to start that, you need a nucleus. You need two of these guys to get close enough to each other that they actually stick together. And then the rest of them will just sort of pile on. Okay, and that's when that crystal, or that the stone, the kidney stone, will continue to form. Okay, and so you can kind of tell that, well, okay, if I'm starting to get kidney stones and they're detected, then maybe I can just put more water in. Maybe I can just stop, control my diet, so whatever it is that's causing these crystals can, won't keep adding to them, and then I increase some water, and there we go, we can fix it. And that's actually, one of the treatments that you can use as long as they aren't too advanced and they aren't causing too many problems. Okay, so presence of a nucleus for crystal formation, deficiency of inhibitors of stone formation. So we do have, that's one of the interesting things, is that some people may have high levels of these basic units that, like the calcium oxalate, that are found in there, and yet they don't form crystals, or they don't form kidney stones, and another person might. And a lot of times it has to do with, there are certain other molecules that will interfere with the ability to form these crystals to begin with, and some people may have more of that and some people may have less of that. Okay, so it's not a sure thing exactly who's going to get kidney stones and who isn't. Okay, so growth into a stone via crystallization or aggregation, so that's kind of what I was just talking about with all of this. And the stones can be calcium oxalate, calcium phosphate, struvite stones, which are magnesium, ammonium phosphate, and then uric acid, which is also associated with gout, which is also the formation of crystals. Okay, so gout are like kidney stones in your toe, usually, uh, where the temperature is a little lower and blood isn't moving as fast. That can cause a gout. Well, same thing can happen in the kidney. Okay, this uric acid from urea can build up and cause stones to form. Okay, so pain. So pain's one of the big things about the renal calculi or the kidney stones. Two types of pain that your book describes: renal colic, which means that it starts and stops, and then non-colicky pain, which means it uh, lasts, kind of goes on. So colicky pain starts and stops abruptly and accompanies the stretching of the collecting system or the ureter. So when that happens, when fluid starts to move through or something like that, then you may see some stretching, and that may cause pain if there's an obstruction, or if these crystals start to move, these stones start to move. Acute, intermittent, and excruciating pain in the flank. I've heard some people say that it's the most intense pain they've ever experienced. Um, so do with that what you will. That's what I've heard. Excruciating pain in the flank and upper quadrant of the abdomen on the affected side may radiate to the lower quadrant of the abdomen, bladder area, perineum, or scrotum. It all depends on sort of where these crystals are found. Non-colicky caused by stones that produce distension of the renal calyces and renal pelvis. So remember, when we're talking about a kidney, the renal calyces and renal pelvis are kind of in this area. Okay, so if you have distension or you have a backup, then as fluid starts to move in and drain into these areas, then you have the stretching, and the stretching may cause pain. Okay, the renal calyces and pelvis. Intensity from mild to severe may be exaggerated by drinking large amounts of fluid. So there we have a situation where maybe you need to drink fluid to sort of dissolve these, but if there's such a blockage that the fluid, you're not able to pass the fluid through, then that can actually cause other problems. Okay, and this is going to be an indicator. Okay, so this different type of pain is going to be an indicator that, well, you have a blockage that may need some immediate attention, or may need a different kind of attention. Okay, so this is another list of the types of kidney stones that are out there. We didn't mention cystine, which is more inherited. Um, because you're not able to metabolize the cystine properly. Treatment overall, so there's a whole list of treatments here, but treatment overall: dietary changes, if that can work, depending on the type of stone. Pain relievers, high fluid intake, and then of course you can always go in and just take the stones out. Not that it's simple, but that can be an option. Okay, so neoplasm. So now we're talking about tumors or cancer. Okay, Wilms tumor. Okay, most common malignant tumor of children. Okay, so I put two down here just so you can be familiar with a couple of different tumor types. Wilms tumor, most common malignant tumor of children 3 to 5 years old. Most common signs and symptoms: large asymptomatic abdominal mass. Okay, so this is a tumor in the kidney. So a large mass that may form. Um, Another sign and symptoms: hypertension. Okay, so that can come from the blockage. I mean, if any blockage takes place, which it probably will. Now, treatment: surgery, chemotherapy, radiation, long-term survival, 90% survival rate with aggressive treatment. Okay, so this is in children. It's called Wilms tumor, and it is a tumor, and but it has a fairly high success rate with aggressive treatment. However, now, contrary to that, adult renal cell carcinoma. So adult renal cell carcinoma, it's about 3% of all adult cancers, which is, it's a respectable number. Arises from tubular or ductal epithelial. So we're talking about the renal tubules um, and ducts that are found in the kidney. Um, Risk factors more common in men than in women. Don't know why. Smoking, obesity, particularly in women. Again, that's just what the data shows as who's getting it. Occupational exposure to petroleum products, heavy metal, asbestos, acquired cystic kidney diseases. So any of these things have all been shown to um, to be correlated with an increase in adult renal cell carcinoma. It's characterized by lack of early warning signs. So a lot of times it's not known because the kidneys are kind of still functioning and everything seems to be working okay. So lack of early warning signs, diverse clinical manifestations. So it depends on where it's happening and your own body's response. There may be a resistance to treatment. Okay, for whatever reason. Often, and this lack of early warning signs especially means that it's often very advanced at the time of diagnosis. And so treatment is pretty much surgical and the prognosis is poor. Okay, so that's not a good situation. Okay, so those were the neoplasms that we're covering in this class anyway. Okay, so when kidneys fail. Now we know what kidneys do, and so if they aren't doing what they're supposed to be doing, then it's kind of predictable what might happen. So less waste is removed. Okay, so soluble wastes are pretty much thrown out through urine. If the kidneys are not functioning, then that waste is going to remain in the blood. Now there's a reason, and it depends on the particular waste that you're trying to get rid of, but these wastes are toxic. They throw the body out of homeostasis, and they can affect how things actually function in other places, whether it's other cells, neurons, whatever. Uh, it's going to have an effect. Okay, so you may be unable to regulate fluid, so fluid levels are going to change. So hypertension, hypotension, electrolyte balances, so your sodium, your chloride, potassium, all those things that are necessary for a lot of stuff. Muscle function, nerve function, other cell function, all your cells function, and pH balance. Your proteins need a specific pH. Well, your kidneys are actually dumping hydrogen or dumping bicarbonate. That's one of their jobs is to do all that and dump that out in the urine if your pH is off. Okay, so when they fail, that's not a good thing. So we're going to talk about acute kidney injury, which formerly was called renal failure, acute renal failure. So you'll still hear it called that, of course. But your book has taken the new terminology and calling it acute kidney injury and chronic kidney injury, which is chronic renal failure. Nitrogenous compounds build up in the blood urea, nitrogen. Now remember we talked about that as urea. Okay, urea, which is a breakdown product of proteins. So those things are going to build up in the blood. If you don't have an ability to sort of filter those and get those out into the urine, then those can build up in the blood. Creatinine, we also mentioned that, a breakdown product of creatine, which is one of these things that gives the muscles energy. And then renal function approximated by initial creatine level and current creatinine levels and current. So initial and then current. So what were my creatinine levels and what are my creatinine levels, because they shouldn't change that much. So that could be an indicator that your kidney function is changing. So acute kidney injury, rapid deterioration in renal function characterized by progressive azotemia. So azotemia, that term azo refers to nitrogen. Basically, it refers to a very specific functional group of nitrogen. I don't know, nitrogen double bonded to nitrogen and hydrogen. I'm not sure exactly what it is, but azo refers to that. So you're talking about nitrogen waste, which means mostly the breakdown products of amino acids and proteins. Okay, that's primarily what we're talking about. So high blood concentration of nitrogenous waste products, urea, nitrogen, uric acid, creatinine also is included in this group. So all of these things build up in the blood. Okay, so you're going to see an increase in your lab results of all of these things. GFR is reduced. Okay, loss of kidney function, maybe loss of nephrons. So reduced excretion of nitrogenous waste and fluid electrolyte imbalances. Yeah, if your kidney, what's one of the things it does? It controls sodium reabsorption, it controls potassium levels, chloride, calcium, all of these things. The kidney is able to control all of these things. And so if you're losing function, if your nephrons are not functioning properly, or if things aren't moving through properly, then you're going to have a buildup of a lot of these things in the blood, and it's going to throw off the balance that your body needs to function. Okay, so initially it may be asymptomatic. Um, Classification of acute. Okay, so don't forget we're talking about acute kidney injury or acute renal failure. Can be pre-renal. That means it's obstructed renal blood flow. That means going in pre-renal. It means where it's going in. You're somehow obstructing blood flow, which gives us, one of our happy terms, ischemia, which means you've reduced blood flow. Okay, so if you have ischemia, well, that's a problem because you're not getting maybe the nutrients that are needed, and probably especially oxygen that's needed. Okay, intrarenal is damage to structures within the kidney. So you can almost say, okay, well, if I have pre-renal obstruction, then I'm going to end up with some kind of damage inside the kidney, and so I'm going to have intrarenal damage too. And that's exactly right. That's a good logical way to think. If you have pre-renal injury, then it's going to ultimately lead to intrarenal injury, and that's the hazard, of course. And then post-renal, so that's an obstruction of urine flow. So that could be then working backwards, actually. Okay. Um, okay, so pre-renal injury before the kidney results from a marked decrease in renal blood flow. Most common form of acute renal failure, profound loss of circulating vascular volume. What are we talking about? Circulating vascular volume. We're losing blood. Hemorrhage, shock, okay? Something is causing blood flow to the kidneys to be decreased. Could be caused from vasoconstriction, whether that's from vasoactive drugs, endotoxins. Remember, when we talk about endotoxins, we're talking about these little bacteria and the little parts around the bacteria that, when they leak out into the blood, can cause an inflammatory response, which includes vasoconstriction. Okay, NSAIDs, nonsteroidal anti-inflammatories. Okay, those kinds of things. Clinical manifestations: ischemic changes seen when renal blood flow is 25% of normal. Okay, so remember, this is generally pretty well controlled, the amount of blood flowing into the kidneys. When it drops to a fourth of its normal range, then you can actually, then you end up with ischemia. Okay, so ischemic changes, and then when you have ischemic changes, you get damage to the nephron tubules, and acute tubular necrosis can take place. Okay, so pre-renal injury can cause intrarenal injury. Sharp decrease in urine osmotic pressure, which is an early sign due to less sodium being filtered. Okay, so if the sodium isn't moving in, then that's the easiest way to sort of think about this. Actually, I don't know if it's the easiest, but it's the most general way, is that we have this concentration gradient in the kidney where the concentration is higher in the medulla, and then it's more dilute out here in the cortex. Okay, well, a lot of this is controlled by things like urea, sodium, okay, and other salts, potassium, chloride. Other salts, other particles too contribute, but mainly, it's sodium, urea, potassium, chloride. And so if you've decreased blood flow to the kidneys, then this is going to be messed up. Okay. Disproportionate elevation in the ratio of blood urea nitrogen to serum creatinine, because urea can no longer be reabsorbed and creatinine never was, and that's kind of true. Um, the thing actually too, I don't know if this is specifically accurate, but the thing to remember is that urea is contributing to this concentration gradient. Okay, I'm not going to test you on the details of how this concentration gradient takes place, um, at least not now. Um, but urea contributes to that. And so if the urea isn't moving in, or if things aren't moving through properly, then it will mess with this overall concentration gradient in the kidney. And that's really important for kidney function. Okay, so you start to see the blood levels of urea increasing in the blood, okay, compared to the creatinine. Okay, so urea that would be um, disposed of is now staying in the blood, and so you see that kind of creep up. Okay, this ratio of BUN, or blood urea nitrogen, to creatinine. Okay, so yeah, like I said, normally GFR can be maintained despite a broad range of renal blood flow, um, but in this case, something is leading it to not be able to keep up that way. So okay, so that was pre-renal. Here's intrarenal injury in the kidney. Results from conditions that cause damage to glomerular, tubular, interstitial structures within the kidney. So now we're in the kidney, and this is a big one right here: acute tubular necrosis. Now we know what necrosis means. It means cell death. Okay, and usually it's cell death. It's not apoptosis. It's not that the cell has decided to die. It's usually from some kind of ischemic event or something that actually caused it to die, and that's the case here. So it's the most often ischemic or toxic in origin. Okay, so we have necrosis of the tubules. Can be post-surgical, so that's sometimes seen. So etiologies, other etiologies: ischemia associated with pre-renal failure. That's the most common, so we've already kind of mentioned that, so hopefully you're able to make that connection. Glomerular nephritis, acute pyelonephritis, so the glomerulus. Um, so damage to the glomerulus, acute, some of those that we talked about earlier. Acute pyelonephritis, so this is the renal pelvis and backup. So something is causing damage in the tubule. So acute tubular necrosis, destruction of tubular epithelial cells with acute suppression of renal function, and we can kind of see a picture of it right here. We see damage to the cells of the nephron, okay, of the nephron tubule. So we see this damage here, and in this case we have cells that are building up and actually causing an obstruction, okay, which then can lead to even more problems, and that tubule may be lost forever. Okay, so destruction of tubular epithelial cells with acute suppression of renal function. Most common cause of intrinsic or intrarenal failure. And that is the tubules dying. And that makes perfect sense because that's the functional unit of the kidney. Okay, high risk groups, major surgery, we mentioned that. Severe hypovolemia, so that's a backup into the kidney. Overwhelming sepsis, so that's infection, so that's a systemic infection. Trauma, burns, okay, so those kinds of things can add to it too. GFR does not improve with restoration of renal blood flow. Okay, so your GFR is not going to change just because you have renal blood flow. You still have, in this case, you have an obstruction, which could increase the damage. Okay, post-renal injury. So this is after the kidney. Results from obstruction of urine outflow from the kidneys. Okay, so that means that as urine is flowing out, we have some kind of obstruction that's blocking outflow somewhere. Okay, so blood or urine isn't able to move through the way that it needs to. So it may occur in the ureter, which can come from stones, strictures, which is usually from like scar tissue or something like that that doesn't allow it to stretch. Um, the bladder, tumors, neurogenic bladder, which is well, we know what a tumor is. Neurogenic bladder is where the bladder you can't control uh, uh, emptying of the bladder. Okay, the urethra, prostatic hyperplasia. So that's the prostate gland maybe enlarged, which blocks the urethra and doesn't allow urine to flow out. Okay, so both ureters must be occluded to produce renal failure, except in persons with only one functioning kidney, which that kind of makes sense. Goal of treatment: removal of the underlying obstruction prior to permanent nephron damage. Okay, so permanent nephron damage, obviously permanent means it's irreversible, and so we want to fix that before we get to that point. Okay, so the clinical course of acute renal injury: onset, we're talking about acute, so hours to days. Time from onset of precipitating event: ischemia, whether the event is ischemia, toxic exposure, or toxin exposure, until tubular injury occurs. So this is the onset. So this is the time that it starts until tubular injury begins. Characterized by marked decrease in GFR, resulting in sudden retention of urea, potassium sulfate, and creatinine in the blood. Okay, so that means your blood levels are going to increase. Okay. Urine output at its lowest point, oliguria, that's the term for that. That means that sort of makes sense. If you have a decrease in GFR, that you're going to have decreased urine production. Fluid retention gives rise to edema, so you might see that. You might see edema, high urea, high potassium, high creatinine, low urine output, and these things sort of make sense, don't they? Because all of these things kind of give an indication that we're talking about something going on with the kidneys. Um, Edema, water intoxication, pulmonary congestion. So this blood and fluid that's supposed to be leaving through the kidneys just isn't, and it's backing up into circulation. Neurologic manifestations of uremia progress if untreated. Neurologic, when you've got complete loss of homeostasis, or not complete, but you have loss of homeostasis and your electrolytes are out of balance, then you're going to have nerve function, change in nerve function. Okay, so repair of renal tissues takes place. Onset marked by gradual increase in the urine osmotic potential. Okay, so that's the osmotic potential of the urine. So remember, there are particles within the urine that affect how water and salts move out. Okay, so you might see an increase in the urine osmotic potential, and if you see an increase in urine osmotic potential, that means that maybe water will remain. Okay, which means that you could dump some of that as urine. Okay. Let's see. Fall in serum creatinine. Both of these things mean that you're recovering. You're starting to dump this stuff into the kidneys, and the kidneys are starting to get rid of some of these things. Eventually, tubular function is restored with improvement in urine concentrating ability. Blood urea, nitrogen, and creatinine return to normal. Some mild to moderate kidney damage may persist. Okay, so that's acute renal injury, which means that we know what's coming next, and that is going to be chronic kidney disease. Okay. Chronic kidney disease: progressive, irreversible, and that's the big difference, isn't it? Progressive, irreversible. Destruction of kidney structures, deterioration of GFR, so your GFR goes away. Tubular reabsorptive capacity and endocrine functions of the kidney are also deteriorate. And if you look, this graph is showing that you're losing, that's what the X is for here, you're losing, these guys are just dropping. Okay, remember we had 1 million nephrons and they're just going one by one, just less and less and less. And so all of these things sort of indicate that. All of the things that they're supposed to be doing. The GFR, you have fewer nephrons, you're going to have lower GFR. The endocrine functions, well, each one of these has a macula densa, which means that any one of these can sort of lead to the secretion of renin and these other endocrine responses that are necessary. And so that's going to decrease. Etiologies or the causes include conditions that cause permanent loss of nephrons: diabetes, hypertension, glomerular nephritis. Okay, so that's malfunction of the glomerulus that we talked about in the beginning. Polycystic kidney disease, any of these things can sort of progress, and if some kind of treatment or some kind of cure isn't found, if I could use that word, means that you're going to, it's going to kind of progress into this chronic phase. Symptoms occur gradually and not evident until the disease is far advanced, so you may not even notice it if you weren't aware of it before. And again, each kidney contains about 1 million tiny nephrons. A proportional relation exists between the number of nephrons affected by a disease and the resulting glomerular filtration rate, which is what I just said. If each of these is trying to produce urine and filter blood, the more you lose. You've got, in this case, in the bottom, you've got one little nephron that's trying to do the job that a whole bunch of them were doing before. Okay, of course, if you're down to one nephron, you're in pretty big trouble. But hopefully the concept makes sense. Okay, so that's kind of it. Chronic kidney disease mechanisms, manifestations. All you have to do is really think about all of the things that the kidney is doing. Sodium and water balance, potassium balance, eliminating nitrogenous waste. Remember those broken down proteins and amino acids. Erythropoietin, remember that? We talked about that when we were talking about erythrocytes, red blood cells. Well, that's controlled by the kidney. So the kidney is releasing erythropoietin. That's not going to happen as much, which should lead to anemia. Acid-base balance, so acidosis. Activation vitamin D, the kidneys are involved in that. Phosphate elimination. So all of these things, and that can cause just a whole broad range of issues. Okay. Problems, not all of which we understand exactly how that happens. Pericarditis, we know that chronic kidney disease, you have an increase in pericarditis. We're not exactly sure why, but it has to do with the buildup of nitrogenous waste. So same thing with things like skin disorder, gastrointestinal manifestations, neurological manifestations. We've got a little better handle on that. Sexual dysfunction, all of these things can be infected by chronic kidney disease, which is why we need things like kidney dialysis to sort of artificially allow these toxins to move out. We put the blood in, and then we run it through a dialysis membrane. And we mix it with healthy substances, and then these toxins then can move out, and then you're okay for a little while until they start to build up again. Okay, so this ran pretty long, but that's it for this chapter on renal disorders.